Yeah.
Okay, David, bring them.
Okay, all rise.
Take a deep breath. Just relax.
Thank you. Please be seated.
Okay, ma'am, I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God? Okay, go ahead and seat. Make yourself comfortable there. You've got an aerial mic in front of you.
Okay.
I need you to state your name and then spell it for my court reporter so she can get used to your diction.
Okay. My name is Jamie Bourke. It's Jamie. Last name is Bourke.
Now, I know you got more than that. Can you give me a little bit more volume? Can you guys hear okay?
No? Okay. All right.
Knock them down.
My name is Jamie Bourke. Jamie Bourke.
Ms. Mick,
All right, thank you.
call your witness, even though she's already there.
Yes, the state calls Jamie Bourke.
Okay? Go ahead.
Miss Bourke, where did you grow
Oh,
up?
one thing. We're going to go for this till 3:30, at which point in time we have another one on the video, and then we'll break her testimony and then hopefully finish her up by the end of the day. Maybe not. She may have to come back. She's got outfit issues she wants to talk about, but other than that, I'm just funning with her, okay? Ladies and gentlemen, so we're going to go with this till 3:30, then we're going to go live on the screen, okay?
Thank you. Miss Bourke, where did you grow up?
Here in Columbus, Ohio.
And where did you attend school after high school?
I went to Columbus State Community College for my associate's degree in nursing, and then later on I finished up my bachelor's at Ohio University online.
Give me a little bit more volume there, okay?
Okay.
Okay. What year did you receive each of those degrees?
The associate's degree, 2009, end of 2009, and then the bachelor's end of 2016.
And when did you begin working at the Mount Carmel Hospital System?
I worked there since 2004 as a PCA first, and then I became a nurse in 2010, and then I got a job there as a nurse.
When you got a job as a nurse, what unit did you start in?
I started in a medical intermediate care floor. It was called 6 Tower. It was med-surg, kind of a catch-all sort of floor. I worked there for 5 years.
Can you give us a brief description of what that job entailed?
So I had 4 to 5 patients each shift. I took care of my patients as far as like med pass assessments, normal nursing stuff. And then I was a charge nurse at some point, which meant that I was more in charge of my own patients and all the other nurses on the floor, all the other techs on the floor. And I was a preceptor also on that floor, which is just helping new nurses. They work with you.
After the 5 years in that unit, where did you transfer to next?
I transferred to it was like a research program. It was called the procedure team. I did that for 7-8 months before I went to the ICU in 2016.
And what were you researching in that role?
We were doing research on trying to decrease the hospital-associated or hospital-acquired infections.
And did you say you went to the ICU after that?
Yes, correct.
And around when was that?
Around 2016, February-ish of 2016.
Did you have any training or orientation when you joined the ICU?
Yes, so in the very beginning when you're a nurse, you have like 10, 12 weeks of working with another patient or another nurse. When I went to the ICU, you went back through another orientation period, 10, 12 weeks of working with another nurse in some classes that you have to take, and some online classes and in-person classes.
Did you have any specific training on palliative extubations?
No, just with another nurse.
And when you started in the ICU, was your work similar to your work in the other units?
No, ICU is completely different. Different type of patients, different type of medications, different assessments. Everything is different when you go to the unit.
What shift did you typically work in the ICU?
I worked the night shift, usually 7 p to 7:30, 8:30, whatever time you got out of there. But when I was in orientation, I did some day shifts, and sometimes I would come in at 1500 and do a 16-hour shift.
And what doctors did you work with?
Their night shift doctors was Dr. Hagris, Dr. Husel, and then we were a trauma center for a while, so we had some trauma residents, surgical residents, and trauma attendings.
Now, when you're starting a shift in the ICU, how do you get up to speed on, well, how do you get your patient, first of all?
We start all in the break room. The charge nurse for that night kind of gives us all of our assignments, lets us know what's going on, gives everybody their, if you're on the code team that night, you get assigned to the code team, or the STEMI alert, those sort of things. You get all of those assignments.
Can you slow down just a
Sorry.
little bit? I didn't understand the last thing you said after code team.
Okay. They assign the code team, they assign for STEMI alerts, which is just a heart attack or a stroke alert.
To interrupt you, could you spell that for the record?
Oh, STEMI is S-T-E-M-I.
Go ahead, you can continue now.
Okay. And then you go and get bedside report with whichever nurse is off going.
What is that bedside report typically like?
The nurse gives you a overview of what is going on with your patient, why they're there, all the different medications they're on, anything that happened within that last shift, and anything that you're expecting to happen, anything that didn't get done that day too.
Okay. I want to take you to January 14th, 2018. Were you working that night?
I was.
And what patient were you assigned?
That patient was Miss McDonald in room 7.
Is that Brandy McDonald?
Yes.
Okay. And did you have a meeting with the nurse from the shift before to get you up to speed on Miss McDonald's condition?
Yes.
Had Miss McDonald been your patient prior to that night at any point?
No, although I was aware of her because I worked that night before morning-ish when she came into the unit.
What was your understanding of Miss McDonald's clinical status when you started your shift?
Do you want me to give you an overview of everything, or just when I
Yeah,
met her?
just generally what was her, yeah.
So she was so young. She was 37. She had ovarian cancer that had spread to her lymph nodes and to her liver. From what I understand, she was on the our regular oncology floor. She had been in a clinical trial, which is like an experimental treatment at Erzingmeister Center, which is just Mount Carmel's cancer center. And those medications that she was on, they were worried were hurting her liver, and so they had sent her to the hospital to get treatment for that. That night, 13th going into the 14th, she had become really short of breath, and the doctor had been called to the bedside. She wasn't doing well. She ended up going to a CAT scan and then coming to us. And that's when I knew of her, because I was working that night. And I was in room 6. The floor doctor and Dr. Husel were in the nurse's station right in front of me. And the floor doctor was telling Dr. Husel about this patient that wasn't doing well. I think he was upset because her lactic acid was really high, and he hadn't been notified of that. And he was telling Dr. Husel about him, and Dr. Husel was like, just bring her now, we'll take care of her. It was like almost shift change. So that's when they did bring her after the CAT scan to room 7. The other nurses took care of her, and there I think that was when she went into respiratory arrest, and Dr. Husel intubated her, got her stabilized. Then, we all went home. So then that night was when I came back in. So 7 o'clock, that's when I had her. She was assigned to me. The off-going nurse had told me that she had continued to get worse during the day. They, family and the daytime physicians had talked, and they decided to change her code status to DNR CCA. She wasn't getting better, she kept getting worse. They tried continual renal replacement therapy, which is like dialysis that we do in the unit continuously. And her blood pressures dropped down into the 60s. She was put on Levophed, which is a pressor that helps increase your blood pressure. She was put on vasopressin, same thing, helps increase your blood pressure. She was on a bicarb drip that was to help for her acidosis. Her pH at the time that when I came on was like either 6.8 or 6.9. That is not good. It is not good at all. Her lactic acid was like 27. So really she was in the part where she was, oops, sorry. She was actively dying at that point. I was told that she was maxed out on her pressors, which just means that we can't go any higher on those pressors. And they gave me the last ABGs. They had it on a sticky, that's what a sticky note, that's why I remember it. And she was getting a bolus to try to help increase her blood pressure, because I think at that point her pressures were in the 70s.
Okay, thank you. I'm going to show you.
Hold on.
Oh,
You
sorry.
said ABG?
ABG is an arterial blood gas, kind of
Okay.
gives us,
I just wanted to know what it was. You guys use acronyms all the time.
I'm sorry.
I get confused, so.
I already showed these to defense, and we've agreed just to publish
Okay.
instead of walking back and forth. I'm going to show you States Exhibit 5E. All right. Down here at the bottom, is this one of your nursing notes from that
Yes.
night?
Yes, that's one of my nursing notes.
And could you tell us the significance of what you were charting and why you were charting at that point?
So when you come on, we do assessments. So first thing, I had gotten a report and I went to do my assessment. Her blood pressure was still low even after she had gotten the bolus. And that's last lactic is what was on the ABG, what was her lab results. So I was calling to let him know that what her lab results were and what her blood pressure was.
Right. And then turning to the next page of States Exhibit 5E. Is this your next nursing note from that night?
Yes, but we had other things that went on in between there. But yes, that's my next nursing note.
Okay. I guess could you tell me what other things went on in between where we were and entering the DNRCC code change?
So earlier in the day, I think the chaplain's notes and the physician's notes had said that if she continued to deteriorate, that family wanted to withdraw care. So they wanted to do a terminal withdrawal or a palliative withdrawal. So at the point that she wasn't getting any better, and I had let Dr. Husel know, the family was either in the waiting room or he was calling them to come to the bedside to let them know that, she wasn't getting any better and what did they want to do. And this next note is where all the family was there. I believe the chaplain might have been, I don't know.
It's okay, I know it was a long time ago.
Yeah, I was there. Dr. Husel came in to speak with the family to let them know that she wasn't doing any better and to ask what their next steps. Did they want to keep her the DNR CCA and we would continue to do what we're doing, or did they want to go ahead and withdraw care, which is what they had said earlier in the day they wanted to do.
Okay. To the best of your memory, who all was present from her family for this meeting?
She had a lot of family in the room. I know that her mom and her dad and her boyfriend, husband, her long-term boyfriend was there in the room.
And as a result of this discussion, is that when the code status was changed?
Yes, that was, then I received orders for the palliative withdrawal.
Okay, and can you tell me about those orders?
Sure. So Dr. Husel gave me an order for 1,000 of fentanyl, 1,000 micrograms of fentanyl, 6 milligrams of Versed. I went into room 6 to put those orders in. I put in a palliative withdrawal order set, and I put in the order for 1,000 micrograms of fentanyl. I notated on there that it was for palliative withdrawal, very clear what it was for. I put in the order for Versed. I then went and talked to my charge nurse because I didn't do these very often. I wanted to make sure I was doing it right. I talked with him and asked him if he would go in with me to do the palliative withdrawal.
When you say him, sorry, are you referring to your charge nurse?
My charge nurse. That nurse that day was named Jason Schultze,
Okay.
and I do not know how to spell his last name.
It's SCHULTZE. Continue.
That's to help and not
Yes, to help
interrupt.
Sam, not for you, yes.
And he just said that yes, he would go in with me. I just mentioned to him, I was like, hey, he ordered 1,000 mics, and he was like, yeah, he does that. And I was like, okay. I went to the Pyxis to get the medications out. I overrode just like I would have done with any other physician giving me a verbal order with a bedside procedure. Removed the medications. As I was removing the medications, another nurse, Tyler Redmond, had come up to me, saw what I was doing, asked me about what I was doing, told me that I needed a bigger syringe, went to our storeroom and got me a bigger syringe. And so then I took my meds and my syringe, I went to room 6. I didn't have a patient in room 6 at that point. We have all of our supplies in our rooms. So I drew up the medications while I was drawing them up. They're in little vials. Dr. Husel was standing there talking to me, and he was like, oh, you have to, do all those little ones. And I was like, yeah, this is kind of a pain. And he was like, oh, well, in the OR, we have them in 400 microgram vials. So they're, in a bigger vial in the OR. And he said, this is the dose that we give before we do the first incision for open heart surgery. And I thought, well, great. If it's enough to cover the pain for open heart surgery, then obviously it's going to be enough to cover the pain and the distress that this lady is going to have when we remove her from the ventilator and she, in essence, suffocates to death. So I said, great. Finished pulling all of that up, got my charge nurse. We went into the room. I don't remember if all the family stepped out or if only, I feel like there was one other person in there because I remember warning them that there was going to be a noise because there's a gurgling noise when you take out the endotracheal tube. And so we gave the medication, turned off all the medications that were keeping her alive, and withdrew the tube. Then family came in. I believe the chaplain was there at that time also. I left the room. I went to the nurse's station to catch up on all my charting, everything that we had just done.
Okay. To unpack a few things that you just touched on, when you removed the medication from the Pyxis, did you say that was via override?
Yes.
And were you doing that, was this a planned procedure or was this more of an emergent situation?
It's not an emergent situation, but it is urgent. But I didn't override because it was emergent. I overrode because it was a bedside procedure, that the physician is there giving me orders, and in that case, we are allowed to.
So Dr. Husel was standing with you?
He was within the nurse's station, within eyesight. I don't believe he was standing right next to me, whereas when I was pulling it up, he was standing right there with me.
And to clarify, did you wait for a pharmacy review before pulling that?
No, they reviewed and approved it later.
All right. Why did you take the vials of medication to the separate room?
Because that's where all of our other syringes were, like the syringe for the Versed for me to be able to pull up all of our flushes were, all of our needles are. So that's where I went to get them all.
Right. And after you said you left the room after you administered the medication, how did you come to learn of Miss McDonald's death?
So we have monitors, like the monitors in the room, you can turn to a certain setting so the family doesn't see or hear all of the beeping, but we can still see it at the nurse's station. So I could watch on the monitor at the nurse's station.
And what would you see on the monitor then?
You could see her respiratory rate, you could see her heart rhythm. She had an arterial line in, so you could see what her blood pressure is continuously. You could see what her saturations were for her oxygen saturations. And did I already say heart rhythm? I think so. Anyways, heart rhythm, that too.
And were you the person that called the time of death?
No, I'm not a doctor. Doctors have to do that.
So would that have been Dr. Husel?
Yes.
Was he with you at the time or when you're watching the monitors, or did you have to notify him after the fact?
I don't remember.
Okay. And I would like to go through some of the medical records with you. I think that you were referencing, well, before we switch off of State's Exhibit E5, were these your final 2 nursing notes of that night?
Yes, so after someone passes, you have to call all of their consults and let them know.
And is this the 2205, is that the time of death that would have been called?
That is the time of death, yes.
And then just looking at this one, the 2130, is that when the conversation would have taken place?
Around that time, yes.
For the DNRCC?
Yes.
All right, this is State's Exhibit 5F. Starting with this respiratory rate, could you describe what that is and what you're charting here?
So the respiratory rate, they have monitors on or leads on that go to the screen that tells you what the respiratory rate is all the time. Respiratory rate is just how fast or slow you're breathing. There in the beginning with the other nurse, she obviously was breathing pretty fast, 39, 38. 2130 is around where I extubated her. So 2151 was minutes after, or sorry, 2151 is where I extubated her. So, or around there. So her respiratory rate was 19. 2156 was a few minutes after that. It was just another vital sign charting that I did. And then 2205 is when she had passed.
So does the 20 indicate that her respiratory had gone up after extubation initially?
Yes.
And then is the 0 is when it goes down for the time of death?
Yes.
All right. On the second page of State's Exhibit 5F, can you discuss what this pulse oximetry is and why you're documenting that?
So that is another vital sign that is taken continuously. This is how much oxygen basically is in her blood or that she's getting. You want them to be between 90 and 100, which is a normal. So she was still on the ventilator at 2130. You can see her saturations are 95. 2151 is around when I had extubated her. You see her sats are now 78. 2156, they're 49. Obviously, they're going down because she is dying.
Going to page 3 of this exhibit. Starting here, the device FiO2 percentage.
So that's how much oxygen she was on with the ventilator. The ventilator has different settings, and you can have it set to where it does the entire respiratory cycle. It breathes for you, so how much oxygen you're giving, how long their inspiration, how long their expiration is, how many times they're breathing a minute, and that's just, they were on 40% of oxygen.
And then turning to the pain scores, looking at these last two, when you documented the 10, was that is after the decision to do the DNRCC, correct?
Correct. That was when I extubated her and gave her the fentanyl.
Were you observing pain at that time, or was this an anticipatory pain score?
This is an anticipatory pain score, what I thought.
Could you
was
elaborate on what that
structural.
means?
Sure. So when someone's on a ventilator, completely dependent on the ventilator to breathe, and then you remove that, they are no longer going to be able to breathe, or at least breathe well enough to, keep themselves alive. And when you remove all the medications keeping them alive, that, in essence, they suffocate to death. So that was me saying, I think this is going to be incredibly distressful and horrible for my patient. So that's why I'm giving her the fentanyl.
And had you observed her to be in any pain prior to giving her that 10?
My first assessment there is 1944, and I put a pain score of 0. When I looked back, when I looked back, I saw like her heart rate was high when I first came in, her respiratory rate was high. So she most likely was in a little bit of pain, and I was too focused on her blood pressure dropping to realize that.
Turning to the next page of this exhibit, is the pain level acceptable?
I charted at 1944 that it was 0, so yes, that it was acceptable.
The next page of the exhibit, looking at the eye-opening response, Glasgow. Could you tell us what that is?
Sure. So that is a coma score that we do whether or not our patient is having certain responses as far as when we call their name, do they try to open their eyes? Do they look at us? Do they have certain reflexes? It's a neurological assessment. She was, all of her organs were shutting down, so I wouldn't expect a response. So since the beginning, or since that morning, she hadn't been responding. She had been unresponsive to us.
Okay. Turning to the next page of this exhibit, the verbal response, is that on the same Glasgow coma?
Yes.
And when you're scoring her a 3, what does that mean?
So the computer adds it up together, and 3 is just the lowest of that coma score. When someone's a 3, there is a order that you have to call LOOP, which is our organ procurement here in Columbus, Ohio, and you have to notify them that you have a patient that could possibly be an organ donor, is why you have to call them.
Now, looking at the next page of the exhibit where we see oral secretions, and you put none and see below, could you discuss what that means?
So the oral secretions are just like what secretions she had in her mouth. It would be that next over where it says, is the patient having pain? There was a whole lot of places we had to chart the same things over and over again. So this, if you see where it says T391 and T425, those are just little things that we annotate. Like if you look down, it says patient unable to self-report pain, unable to self-report pain. So that was me charting that.
Turning it to the next page, are these your notes when they had those little T?
Yes, that she was intubated, sedated, that she was over-breathing the vent, and she was guppy breathing. What I mean by guppy breathing is that she was going, and that does happen when someone's pH is so low and when they're actively dying. So, yeah, and that other one is when I withdrew from the ventilator. When you put the pain score in, the program makes you like go through a couple different things, and that's one of those that it makes you do. So that she was unable to self-report pain, that I was giving this medication anticipatory because I was removing her from the ventilator.
And what is the significance of patient over-breathing the vent?
I'm sorry, I didn't hear.
Where it says she's over-breathing the vent, what is the significance of that?
So, well, one that showed that she was in a little distress or some distress. Like I said, I should I should have noticed that. But so when people are in distress, they're breathing really fast. So the ventilator is set on a certain rate for her to breathe, and she was over breathing that rate.
Then, just looking at this last one, pain relief, when you put C below, what are you documenting there?
So T421. So this is one of our, you see I did it at 2009. This is every 2 hours we have to chart certain safety things. And this is just one of those every 2 hours you have to chart, like, what sort of interventions are you putting in place that your patient isn't in pain, or that you're taking care of your patient? And that would be comfortable environment, peaceful environment, positioning, rest. Those are all interventions that we do kind of continuously to help our patient.
And was this and the 0 pain scores before or after the order was given for the fentanyl and the midazolam?
It was before.
Just turning briefly to State's Exhibit 5G, is this the note that you were talking about where you documented?
Yes, so when I put in the order for fentanyl, I specifically put for ventilator withdrawal, so pharmacy would be aware of what I was ordering it for, and I know that I did that because I misspelled withdrawal, so.
And finally, turning to State's Exhibit 5H, is this the medication administration record for Ms. McDonald?
Yes.
And looking at this right here, were you aware of this administration of medication earlier in the night when you started your shift?
I don't remember if I was aware at that point, unless I would have seen it on the MAR.
Did you become aware of it at any point during your shift?
I don't remember.
Okay. The next page of the same exhibit, is this the order for the midazolam and the fentanyl?
Yes, those are the orders I put in, and those are the medications that I gave.
And it looks like, what time was this order put in?
I put them in at they should be 21:31. Yeah, I put the orders in around 21:31 after we had the discussion with the family.
And what time did you administer them?
Around 21:51.
Right. I have no further questions.
Baz, we got about 5 minutes before we have to cut. Do you want to do it now, or do you want us to do it all at once?
I don't think I'll be long, but we both know how that goes.
I'm gonna take a chance on you. You're the one who'll get cut off.
It's up to the jury. If they want to take a break now.
We're not taking a break, we're going to go to Dellinger
Oh,
at 3:30.
oh, in that case, yeah, I will
Okay.
make use of this 5 minutes.
Let's take 5 minutes so we can get the screen set up for the next witness.
He said the other thing.
Oh, you wanna do the questions?
It's all right.
Well, everybody was talking, I was talking to you, so you got everybody's input. You wanna do it, do it.
Sure. Good afternoon, Ms. Bourke.
Hi.
Just a couple quick questions before we have to break. You mentioned that the pharmacy verified it after the fact, correct?
Correct.
And that was this all occurred, and I'm just showing you I'll just bring up State's Exhibit 5H. The date of all of this occurred on January 14, 2018, correct?
Correct.
And the pharmacist who verified the order was Talon Schroyer, correct?
Correct.
And fair to say that January 14th, 2018 came before October 24th, 2018, correct?
Correct.
I'm ready to take a break now.
No, you're still going,
You
dude.
want me to keep going?
Yeah, I wanna see if you can get it done in 5 minutes.
No, I didn't say I was gonna get it done.
Ah, you stepped up.
I'll keep going.
Let's get a couple more minutes of it.
Now, having said that, you said you testified under direct examination. I'm showing you Joint Exhibit 5, page 286 to 287. This is the same document you went over with the prosecutor, right?
Correct.
Now, the event was set at 30?
I don't remember.
Okay. Actually, 34. Does that sound correct?
It could be.
If I showed you the order that was entered earlier that day, would that help refresh your recollection?
Yes.
May I approach?
You may, or you can show it to her on the screen. You guys all stipulated the records.
All right. Showing you Joint Exhibit 5, page 172. Do you see right there where the order for the ventilator is set at 34?
Yes.
Okay. So when someone is, as you mentioned, breathing over the vent, that would show, it would have to show over the number 34, correct?
Correct.
Now, here, earlier in the day at 6 p.m., 1838, which would be 6 p.m., she's breathing at 39 breaths per minute, correct?
Correct.
Now, the normal rate, respiratory rate, would be between 12 and 18,
Correct.
correct? So she's breathing pretty fast,
Yes.
breathing even faster than the ventilator is breathing for her,
Yes.
okay? And she's doing that throughout the day for hours.
Correct.
And right around here is where she gets the palliative withdrawal, correct?
Correct.
Now, can you tell the ladies and gentlemen of the jury about when a patient tires out on their respiratory rate?
You mean as far as within the palliative withdrawal or just
In general, with their reserves.
So at first you would see usually someone breathing fast. They're going to be breathing fast, kind of huffing and puffing. Usually they look like they're in some distress. Sometimes they're like wheezing, that sort of thing. And then as it wears on, then the respiratory rate decreases. As they're tiring out from breathing too fast.
So a person can eventually stop breathing because they've been breathing so fast for so long.
Correct.
Now, when Ms. McDonald had the withdrawal, her breathing was at 19, freshly off the vent, correct?
Correct.
And then it actually went higher, correct?
Correct.
And that was approximately 5 minutes later?
Correct.
And you would have given the fentanyl before extubating her, correct?
Correct.
So this tells you that the fentanyl did not affect her breathing, correct?
Sustained. Good time for a break. Because it's getting close to our time. Ladies and gentlemen, we need a couple minutes to set up. I'm going to send you out of the room. Stretch your legs for a second, and we'll get started in a couple minutes.
All rise.
Do we have Paul? Okay. Just relax. We'll take care of you, don't worry.
Everything, man, you just turn around and blame me. God, it's that time.
Okay.
Stuff.